pathology and specific diagnoses and walk you through some of that. But I really think in the last couple of days, I decided to pivot to some other topics because I know that we had really gotten into some of that already because we had really talked about the different diagnoses through the lens of developmental and intellectual disabilities. But tonight, I'm going to try to make it as generalizable as possible, not only for the population that we're talking about, that we're dealing with, but for yourselves when you are deploying for whatever reason. Again, it can be due to a storm, a flood, public health emergency. God forbid we have another COVID, or we're celebrating again the Birds winning the Super Bowl. There's a lot of different good and bad reasons why you may have to deal with these subjects. One of the general issues that goes across all populations is what we have here in front of us, which is substance use and abuse. Formally in the DSM, the Diagnostic and Statistical Manual of Mental Disorders, it is listed individually by drug type, substance type. I'm going to use those words interchangeably tonight. Substance use is also synonymous with abuse, but in the newer DSM, it calls it use instead of abuse for a lot of different reasons, but a lot of it having to do with stigma. Believe it or not, that does make its way into the research and the DSM and how we go about treating and recognizing these types of things. But you all work and deploy in a city. I come from a suburban area where I'd be crazy to say that drugs aren't an issue in any setting, whether that's a high school, God forbid, I'm hearing about middle schools, college, obviously, you got plenty of those in your town. But when it comes to Philadelphia specifically, there are some really problematic areas. All right, number one, let's talk about cannabis, pot, marijuana, what have you. This is so different from the last time I talked about substance use out loud. It's been about 10 years, and so many things have actually occurred talking about cannabis in that amount of time. I'm not even going to say what the legality is in Pennsylvania or Philadelphia specifically, because by the time you are hearing my voice, the law could have changed. So my understanding is I believe Pennsylvania currently, this is July of 2025, is medicinal, but recreational is on its way to or is already decriminalized, whatever. It's out there. You can smell it on the streets. It's there. Psychologically, you will more than likely have people in a shelter, or even when you're talking to them out and about, under the influence of some of these things. Cannabis being probably one of the more common things next to tobacco and alcohol. You will notice people that are under the influence of cannabis might be a little bit more sedentary or calm, relaxed. Typically, you compare them to people that are under the influence of alcohol, for example, and it's a very different experience. Alcohol tends to get people to be a little aggressive, rowdy at times, also lovey and depressed and all those other things. But alcohol has more of an acute emotional reaction. Cannabis, however, has downsides as well. While you can't overdose on cannabis like you can on alcohol, you absolutely can if you are susceptible to psychosis in your family history. There's a chance that can actually formulate itself for the first time. It's a very bad situation. Quick story. I was working as a psychiatric screener in an emergency department, seeing a patient having nothing to do with this story. And all of a sudden, 5 medical students come through our locked door because they had IDs to be able to get access, unannounced, without security. Nobody's telling us that they're coming. And we're like, okay, why are you in our psychiatric emergency room that is almost full? What happened was one of the medical students, and I'm not saying medical student, he was a resident, a medical resident. So this was a medical doctor still in training, not a medical student. So this guy was in his mid-20s, I want to say. We just finished, I think it was his first year. So I believe we called them interns, teaching hospital. This is what happens. They were working on something upstairs on one of the medical floors. The guy had supposedly been smoking pot the night before because they were studying for something and he was trying to relax, whatever it was. And the next morning, he started acting very delusional. And in the middle of a procedure, he started picking up, I don't think it was a scalpel, but it was something that could be, dangerous. Started going after his colleagues with it. He was paranoid about them. And it seemed that there was, long story short, a history of schizophrenia in the family. Um, and not that that would have never happened had he not utilized the marijuana. And for all we know, he'd been using marijuana for 20 years before that, maybe a little less. Um, but it's something that's suspected to kind of like pull it out of you. There's a correlation. I can't prove through any research that cannabis can cause schizophrenia or any other type of psychotic disorder. However, there's a correlation, meaning there's a relationship. As the use of cannabis goes up alongside schizophrenia, so do those rates of where there's an actual psychotic episode. Cannabis is something I have seen lots of people under the influence on, overdosed where they took, 10 gummies when they should have taken one. I've never seen anybody hallucinating or anything beyond very, very mild delusional thoughts. So if you have somebody that smells like marijuana and they are in a full-blown psychosis, start thinking a little bit deeper. There might be other things going on. There might be other things on board, right? Because just because you smoke pot doesn't mean you're not going to then have a cigarette, a drink, and God knows what else that's listed here. The other big thing I wanted to make sure I talked about tonight was fentanyl. For anyone that doesn't know, fentanyl is a very strong opiate. It comes from the same family as morphine, heroin, tramadol, all the different types of things any of you have ever been on because of surgery, sickness, serious sickness, illness, things of that nature. Fentanyl is something that's manufactured overseas and trying to keep there are a lot of politics involved with this conversation, so I'm just going to leave that out of it. But you could certainly Google that on your own if you'd like. But the issue with fentanyl is that it's very readily available and it's being pushed out onto the streets very easily. So in cities like Philadelphia, for example, there are a few streets where it is almost as if it's an open air market for these types of things. There's issues with that, and then there's issues with people that don't know that that's what they're getting. In a lot of cases across a lot of states over the last several years or so, there has been a major pendulum swing from people getting prescription painkillers, opiates specifically, to we have an opiate epidemic. We are not writing prescriptions for these, and they put in a ton of laws depending on where you live in the country. New Jersey and Pennsylvania are very similar in those laws, where your doctor may have to see you every few days to give you a prescription. And it puts people in a position where it's actually sometimes easier to access that medication through the street, through a drug dealer. And that was some of the argument with cannabis. People, I know in New Jersey specifically, were reporting that they were no longer being prescribed opiates as much as they had been for cancer patients, things of that nature. So people were using cannabis as a way to help with their appetite, and as well as to just help them feel like a human again, feel a little bit more vivacious and alive. And people started going to their corner drug dealer instead of buying it through the right places. And then, cannabis has been kind of taken under that wing and is starting to show that it can be handled, nothing's perfect, but better than buying it from a drug dealer. Same formula, different substance. Now you've got people that may be seeking an opiate, not because and we've talked about this before about, the mom who doesn't realize she's a mom yet, having a drink at at a bar, not realizing that she's pregnant. It's almost like that same thought of like, you didn't realize, you didn't mean to do something that was going to change your life to such a negative level. And I'll give you a personal note of this. I have a history of serious substance abuse in my extended family, where somebody passed away from opiate abuse. And this was years ago. And so I know it's in my family, and something I've always made sure I think about in the back of my mind anytime I have to or am prescribed one of these medications. Speaking about, again, opiates directly, I had a number of neck surgeries over the last few years. I've had 4 neck surgeries in the last 7 years or so. All well, everything's good, nothing life-threatening, everything's happy. But between number one and two, all these substance abuse, epidemically oriented type of opiate laws became validated. And I had a major surgery and there were complications in my surgery. I went to your beautiful hospital known as the Pennsylvania Hospital, had great treatment, but I had a complication during my surgery. I had a cerebral spinal fluid leak, which could be extremely dangerous. I felt fine. Nothing bothered me at all, but I was in a neuro ICU for a week and everything was fine. I was on, the right medications. And then when I got discharged back to Jersey, it was almost impossible for me to get my prescriptions filled for pain. And there was some serious pain. They had drilled through some major parts. I had some new hardware. I was like a mini Home Depot walking around here. And it was a struggle where my doctor had to get on the phone with a pharmacist, had to send specific letters. They were only giving me, I think it was 3 days supply at a time. Um, Big difference between suburbia and a city. I can't walk to my pharmacy, especially if I just had major neck surgery and I was in an ICU. So you can see, and I was able to see, when you make a law about anything, again, no politics, but when you make a law about anything, there's going to be winners and there's going to be losers. And granted, it did save a lot of lives trying to get these opiates off the street, because what was happening was you get somebody like me. Originally, if this was 20 years ago, I'd get a prescription for like 90 pills and they'd give them to me. And I would stop taking them after 5 days because I don't need them anymore. Now I have 70 pills left. Well, now they sit in my medicine cabinet for years, right? I have kids. They are young right now, but when they're a few years older, they'll start looking for those things. Just as a fact of life. They're perfect right now, but they're not going to be forever. That is what some of the issues were. It was literally just having too much of this on the street, too much of a supply, almost like an inflation thing. Like too much money on the street, you got to dial it back. And that's essentially what our government did. And you'll notice if you ever fill a prescription specifically, it'll say class 2, class 3. These medications, those are federal levels that they're assessed at for their ability to be either completely illegal, or each different level of classification comes with it a different set of rules. So level 1 classification, schedule 1, I'm sorry. Schedule 1 is everything that's illegal. So typically speaking, like cocaine, heroin, those types of things are schedule 1, even though there might be some medicinal properties, right? Heroin was figured out and was part of the Bear Company when they didn't know how to do aspirin yet. We used to sell that in pharmacies. There was something called laudanum that we used to dole out. It was a mixture of, I think, alcohol and a liquid opiate. So this isn't anything that's new to us. But by, again, having all this stuff available, a lot of potential for abuse. And people get hooked on fentanyl. I believe fentanyl is like 100 times more potent than morphine, which is 100 times more potent than your typical Tylenol number 3. So if you do the math on that and you're selling drugs, you're going to buy that drug. A lot of times people are buying this fentanyl because it's significantly cheaper. So they're basically throwing more breadcrumbs in their meatballs to make, more meatballs out of that mix, so to speak. So instead of having, 10 pounds, they're able to make 13 pounds and make that much more. But the fentanyl is so potent that it's killing people first time around. Somebody from New Jersey just died. I think it was a birthday party or something. It was like 15 years old, something like that. When we were all younger, people trying things for the first time was considered dumb anyway. But now throwing in the fact that you can literally kill yourself by doing it because you don't know what you're getting is of concern. And fentanyl is a medication that is prescribed. Anesthesiologists use it, but obviously it can be abused. Usually it comes in the form of a patch. So it's a transdermal patch. I actually saw somebody once who, she was a mixture. She was mentally ill and she was very much addicted to fentanyl patches, opiates specifically. And I remember seeing her at basically it was a welfare motel paid for by social services. And she answered the door. She had a lot of physical issues anyway, but I remember her answering the door. You could see they were just like patch after patch, but they were American pharmaceutical made patches. So despite the fact that she was incredibly stoned, under the influence, whatever you want to call it, she lived another day, because even with all of that stuff on there, she didn't have enough that would have been the same amount as if you got it from a drug dealer on the street that's manufacturing it. So that's why you hear so much about it. Going down further, again, the people that you're going to be talking to may be on these things, especially elderly people, people that may have had surgery. Like, there's no such thing as a well-timed disaster, right? Disaster is going to happen. You got a lot of hospitals. Somebody is going to have just been discharged from one of those hospitals from a medical surgical unit. Like, so there's going to be people that are on medications, that are on serious medications. You got to think about making sure that those medications might have a place to be locked up, or a place that a person can say, hey, can I like put these somewhere in storage? Because you don't know who's walking around in a shelter situation. And there will be people that are drug seeking, because for every person you have with a prescription medication, you may also have somebody with stuff on them, and it's not your job to look for, ask for, do any of those things. You're just there to make sure people are safe and have what they need and get the information that's necessary. Moving along, benzodiazepines are basically they're also called anxiolytics. They are medications that are anti-anxiety. Now, one of the best quick little things I can tell you is there are two different types of medications. I'm not speaking scientifically, I'm just for your own understanding. There are medications that take several weeks to work that help anxiety. Those are SSRIs, selective serotonin reuptake inhibitors. There's different types as SNRIs. None of this really matters for you. What it's important for your own world and to understand is those are a specific type of medication that are not abused. Then you have another type of medication that's more for immediate use, like panic attacks. Those are typically your Valium, your Xanax, your Klonopins. Those are all kind of in the same family. These have, again, potential for abuse. Definitely happens in your city, something to be expecting. One of the bigger dangers with some of these isn't so much when somebody's under the influence, because you can absolutely expect, again, people that are abusing and people that have prescriptions that will abuse under the circumstances that they're going to be in front of you with. Let's keep in mind something bad, more than likely. Let's take the Super Bowl celebration out of the scenario, even though people will be abusing drugs for celebratory reasons. But let's keep it on the negative. You've been deployed because something bad is happening. People are going to be anxious. Even people that aren't typically anxious are going to be lower than their normal baseline is. So if you've got people that are typically on medication for anxiety, and it's really a major disaster, or there's potential, or somebody's place of living, occupation, lost a pet, lost a family member, hurt, any of those things that throws somebody off, is going to affect them. And some people will be looking to take some of these medications. Medications will lower the tendency for your central nervous system to react to things. So fight or flight is going to be a lot more dampened. So by the time somebody's under the influence of this type of medication, they're going to be a bit more, I don't want to use the word tranquilized, but essentially that's what we're talking about here. It could make it difficult for them to articulate themselves very well if they've taken too much. They might seem like they're falling asleep. Same goes for the fentanyl and the opiates. The only difference, opiates typically are being taken for a euphoric feeling, whereas benzos are being taken to get rid of anxiety and can produce a euphoric side effect as well. But they work very differently. One of the bigger issues with the benzos, and also with alcohol, which I'll get to, is that there is a major danger for withdrawal. And both alcohol and benzos have a shorter half-life. So if somebody is on medication or drinks every day and they suddenly stop taking that medication or stop drinking, there can and will be some medical level reactions to that. And benzos and alcohol, both while in withdrawal, can cause seizure disorders, not seizure disorders, seizures themselves. And alcohol specifically can actually, withdrawal can cause death. So things to look out for are going to be withdrawal symptoms. People that are a lot more irritable for like the smallest little things. It's going to be those people that stand out to you that you're looking for, or things that are very, I don't say the word obvious, but things that stand out. So somebody that might be shaking. Could be for a lot of different reasons, but either way, if somebody is noticeably physically doing something that's obvious to you or it's catching your attention, I think, and this is something to ask, the people in charge, that is a situation where I think it's okay to walk over to them and say, is everything okay? Is there anything that I can do for you? You're not asking them if they're on drugs. You're not asking them if they're withdrawing from drugs. You're not asking them anything about drugs. You're simply asking a question. Are you okay? Is there anything I can do for you? Because if somebody is withdrawing or somebody's under the influence and they're having a bad reaction or for whatever reason, you are establishing trust and some type of rapport with that person. And you never know, things can go sideways at some point, and you might just be the person that they want to talk to and confide in for that type of stuff. Some additional information: hallucinogenics. I don't expect something for you to run into. I could see somebody being bored and taking it, but it's not really something you'd expect. But that's like LSD, technically ecstasy kind of falls under that, and so does marijuana. Marijuana is considered a hallucinogenic, but it doesn't make you hallucinate in the traditional sense. It's more about how it's being metabolized and functions through the body itself. Stimulants is another one that you will see abused quite a bit in any of the situations. I will go back to the party atmosphere. You will see stimulants being abused. So these are the opposites of benzos. Benzos slow your central nervous system down. Stimulants speed it up. Types of stimulants that are illegal would be cocaine, methamphetamines. Technically, ecstasy is also a type of stimulant because it stands for methyl dioxyl methamphetamine, which is MDMA, which is ecstasy. There are a lot of other types of synthetic type of medications or drugs that are used now. There's spice, there's K2, there's all sorts of different stimulants. Typically, this is stuff that more adolescents, younger men tend to utilize. Club drugs, that type of thing. Not typically going to be something that I would expect to see in a shelter, but you never know. City life, you never know what to expect. Honestly speaking, one of the more dangerous scenarios occurred over the last couple of years, and I see it through my eyes of working in an emergency room where there's almost like a punitive aspect to being in there. You haven't broken any laws, but you're being held against your will. You can't just walk out the door like you can in the emergency room. But through that, I've seen a lot of physical aggression and just difficult patients and things of that nature, whether that was due to a mental health issue, a developmental disability. I would say one of the more difficult scenarios that we've experienced is the cessation or stopping of allowing people to go outside and have a cigarette and trying to balance somebody's, essentially their sanity. Somebody that's used to getting a hit of nicotine, I'm going to call it that because there's so many ways to ingest nicotine and cannabis now. Nicotine is way more addictive, especially when we're talking about how our body metabolizes physiologically. You are truly addicted to that substance in every way out there. It's like the most addictive substance on the planet. Having said that, because our society has embraced cigarettes way longer than we've shunned them, right? We've only started really thinking of cigarettes and tobacco as the devil since like the late 60s, 70s. I might be a little bit off, but 10 years or so. And we didn't get it out of hospitals until like the last 15 years or so. So it's something that we're up against. It's only the last few years where that's been something that we've been able to really try to eradicate. And what happens is we've got people that might be brought in to the emergency room, to a shelter, wherever it is, and they can't leave for whatever reason. And now they're being told they can't leave for a cigarette. I have seen that turn into a physical altercation more than I've seen with anybody having an actual psychotic episode or any other issue. I worked in emergency rooms and all this for almost 20 years. And in that amount of time, I was only physically attacked one time. And it was somebody that was actively withdrawing from heroin, which sounds worse than tobacco, but it was all over him not getting a um, patch, a nicotine patch, quick enough. And he grabbed, there's very little that you can use as a weapon in the psych emergency room. He grabbed a paper towel holder, ripped it off the wall, and was trying to swing it at us. And that ended poorly for everybody. But nonetheless, it was literally over tobacco. So think about some of the places that you're going to be in where these shelters or deployments might be. Those are a lot of places where you're not allowed to have a cigarette. So you got to deal with policing people. You got to deal with trying to refuse somebody, people not having their cigarettes. Like, these are people that are running out of their houses, their apartments, wherever they live, their group homes. And when you are required to have some of these things every day, some of these, again, are prescriptions. Some of these are habitual, but whatever they are, that's something that somebody's used to having every single day, and that's no longer available to them. You're going to have some major issues. So putting that all out there, I'll pause for questions if anyone has some. Sometimes substance abuse questions are something that people want to ask about, but if not, I will move along. If you do want to put any questions in there, please feel free to put them in the chat. But yeah, like, nicotine is a real tough thing out there, and serving public health, you're supposed to shun it. You're supposed to say this is bad, but when you're dealing with a disaster and a mental health episode on top of all of that, the cigarette is a lot less important and pales in comparison to the other things that you're dealing with at that point. So it's okay to move on and see what you can do. Okay. This, I think I showed to you briefly last time, but I wanted to go through it because I think it's a good method of having your ability to take notes on somebody, or to just take notice of something if you are concerned about it and you want to just let somebody else know what it is you're seeing. And it's a good thing to understand and learn from if you are somebody that does work with mental health disorders in your own life or wherever, and it's something that you can kind of introspectively or insightfully look at for you. One of the first, and this isn't the entire mental status exam, but I wanted to give you a flavor of what these things are, as somebody like me is, sizing somebody up for whatever reason, if it's for, a crisis evaluation, a de-escalation, whatever it is. There's a lot of things that we're looking at that aren't, quote unquote, scientific or clinical, that you can use for your own benefit. First thing that we typically look at is appearance, right? Is the person in front of you, again, keeping in mind deployment, not in a mental health situation, did that person show up to you looking disheveled or neat, right? Again, the context of disaster implicates somebody might have had a rough morning or a rough night. They may not look like they just got themselves all dolled up for the night. But keeping those two things out of your mind, there's also some other things that you can take note of. Is their dress appropriate, or is it bizarre? And I mean, with all the cultural aspects that you can in mind, and that can get really difficult at times, but specifically looking at inappropriate observation of appearance, my best example would be, today's July 14th. It's a rainy day. It's 80 something degrees out. Either way, if you had a deployment today and you had somebody in front of you that was wearing a winter hat and gloves, that would be what we would consider to be inappropriate appearance. That, to me, is sending me a message that this person is disorganized in their ability to think and to prepare for the day. It's an executive functioning issue. It could also be an attention-seeking issue, which is why bizarre observations aren't always going to be helpful. And this isn't a single observation in a vacuum. You're taking this one observation and looking at all these other areas and seeing if a cluster of things together is giving you an idea as to what you might be dealing with. Okay. Kind of like how we looked at, if you remember a couple of weeks back, we looked at all the disorders, right? You got all these disorders with all this very specific criteria that we've gone over in the past, right? It's there for a specific reason, to make sure we're not just painting a broad brush, because mental health, we don't want to do that. And again, mental status exam isn't giving a diagnosis. It's just giving you what is in front of you in a more objective manner, even though it still is kind of subjective. Right? Speech. Is it normal? Is the person talking like I am with appropriate inflection where my voice is going, the pitch is going up when I'm trying to talk about something more interesting? Am I using good eye contact? Even though this is virtual, you could tell if I was looking in the wrong direction or I kept looking around the room, and it would make you think like, okay, something is weird going on with Jason today. He normally looks right at us, and today he's looking out the window. You can't tell there's a window there, but there is. But just even the observation of seeing what's in my background can appear different or intense. Am I staring at you like that, where it's making you uncomfortable? You've seen people with that before, lack of a better term, my kids call it the crazy eyes. You see somebody like on the subway that's giving you a real uncomfortable look, that's intense. It's not appropriate for the situation. If somebody's watching their apartment building burn down and they have that same look on their face, it's intense, but it makes sense. It's appropriate for what's going on at that moment. Avoidant, avoidant eye contact to me could be anxiety. It could be paranoia. It could be something physical or psychological. So I'll give you, for instance, again about me, eye contact. A lot of times when I am really tired, I was born with what's called strabismus. My right eye is what you would probably refer to as a lazy eye muscle. So if I get very tired or fatigued, my right eye will start turning in. I was like 12 years old before that ever got fixed on a longer term basis. Because of that, even today, there are situations where if I feel like my eye is doing anything, I will avoid eye contact with people, even my own wife, my own kids. It's just something that's in my brain. That does not mean I am experiencing anxiety or anything else. It's just something that I do. So again, that's why we don't take these things in a vacuum. Just having avoidant eye contact doesn't make you a suspect for a crime. It doesn't make you paranoid. It doesn't make you any of those things. It just is what it is. And sometimes there's a very legitimate reason. Eye contact is sometimes against culture. Western culture says you're supposed to look at somebody in the face, shake their hand. Some other cultures don't do that. Some other cultures find that inappropriate or even insulting at times. So again, it's knowing your audience and knowing what is going on. Motor activity. This and eye contact can be helpful, and speech, actually all of these, for substance use stuff. You can really get a good flavor of what's going on looking at all these things together. But motor activity, is it normal? Are they sitting where they're supposed to or how they're supposed to? Are they restless? And again, you're in a shelter or a deployment. Some restlessness is absolutely expected. Restlessness doesn't mean, people biting their nails, or, the more modern thing is somebody like moving their leg up and down a lot. Those are essentially self-stimulating behaviors. And that doesn't mean that you are neurodiverse or you have autism or any of those things. We all have sensory needs in our lives. That's why we like certain types of foods and like certain types of clothing and all those other things. There are appropriate aspects of behavior and not. Facial tics or slowed motor activity. Tics is something that would probably be something with anxiety or more of a medical condition, but something, again, to be looking out for. Slowed motor activity. I told you all a story about how I had a client who was just getting more and more depressed. It was the gentleman I told you had Down syndrome. He was 25, and they kept discharging him from the hospital, even though he kept saying he was suicidal. And then he eventually was seen by me and really had a poor mental status exam because his reactions to how he was talking was slower. He was so depressed that his central nervous system was actually becoming depressed, in how the word actually means and where it comes from, was getting truly depressed or slowed. So those are things to look out for. It can also mean a physical issue, a medical issue. It could mean that somebody might be using heroin or something else. Again, it's all in a cluster together. Mood is an important one for you guys because most people shouldn't be euthymic, meaning happy or elated, the happiest they've ever been when they're seeing you guys. It's nice to see you all, but they're probably seeing you on a bad day. The more appropriate mood would be anxious, angry, depressed. Euthymic, euphoric, not what you would be expecting. So that would be something that I would be suspicious of, along with other things. Cognition, we went over this quite a bit over the last 7 weeks, talking about different types of cognitive issues. impairments, but it also gets into memory, because we're not just talking about intellect when we talk about cognition. We're talking about how is the brain functioning in what we're demanding out of it. So can a person remember what their address is, where they came from, when was the last time they took their medications? Those are things that are important to be able to respond to. I'm going to skip around a little bit. We talked about the hallucinations. We talked about the delusions. Suicidal and homicidality are very obvious. Any of these things should be getting somebody that is a professional in the field to talk about what's needed for that person. That's not something anybody should be working on by themselves. Behavior, we live in a society now where I was just reading an article before the training about how you know somebody boarded an airplane and they made an announcement because they are allergic to peanuts, and they were asking everybody to not eat peanuts on this short domestic flight. And I couldn't believe the commentary about how selfish people are, in that they were saying, book a better seat next time. Not that that has anything to do with allergies. Book private, all these very empathetic type of statements about them saying, if I want to eat peanuts on an airplane, I'm going to do it, even if it kills you, which is absolute insanity to me. But for whatever reason, that seems to be the increasing norm of how people are behaving in society. People talking on their speaker phones, all those different things where not so many years ago, people were thinking of other people around them. There's a lot of selfishness that's bubbled to the surface, especially since social media has become such a focal point in our society. And it is eroding some of that. And when you have people in I'll call it a tinderbox, you've got people in a high school gym on cots following a very disruptive shared experience, you might have some people that are looking to be cooperative. You're going to look for, there's going to be people that want to help. There's going to be people that want to do stuff for you guys, that are going to try to thank you for being there. And then you're going to have people that are going to be aggressive or entitled. And that doesn't mean that they have a mental issue. It means they're dealing with something. And unfortunately, you might be the recipient of that anger or animosity, because you as a volunteer being there, they might assume that you didn't experience the disaster that they just did. Anything's possible with human behavior. But again, looking at all of this together is an important thing. Insight and judgment are a little bit more subjective as far as being able to evaluate them. But insight is, is that person truly understanding like the gravity of the situation? Are they talking about moving back in tomorrow when, the street is completely flooded and half the house is gone, things like that. Are you going to need to try to refer them to something further on for them to get that type of treatment? And that kind of leads me to the next part, and the most important part. And I know this is something that you all do get training on, or have the option for training at some point. But I wanted to take the opportunity that I have your attention to talk about why it's so important, and why you as a volunteer and not a licensed person in the field like myself is someone that really is the ambassador for doing this, and is the more appropriate person to do that. The state of Minnesota has a great website about this, where I just literally just pulled this information from to be able to talk about it and for you to have a reference point. There's 5 essentially pillars of psychological first aid. Technically speaking, by the time these people are in front of you, the first one's already been accounted for, which is safety. You guys should hopefully be deploying in an area that is safe. It's set up so that you guys could be there for the long haul to deal with all this other stuff. So just by design, safety should and hopefully be accounted for. But you as a volunteer should always be concerned about your safety primarily above anybody else's. Because if you're not safe and able to care for yourself, you're not going to be able to care for anybody else. The next is calm and comfort. As a volunteer in a situation, you're representing the whole system. Everyone's going to assume that you're connected to the federal government, FEMA, and everything that comes with that. Some people watch the news, some people don't. Some people will have opinions, some people won't. But you're acting as an ambassador right off the bat. You're checking that person in the moment they're walking through the door. How calm and comforting are you being in that moment? I know you're dealing with stuff, because if you're being deployed, then something's happening in your backyard, or your friend's backyard, or your family's backyard. So that's something that you need to check in on yourself before you start helping other people? Are you going to be in a good psychological state of mind to be able to provide this psychological first aid to others? Then there's that connectedness that you're looking for. You have a shared situation. Most situations where there is a lot of stuff going against you unites people. It's that shared humanity type of thing where you feel that connectedness to people because you're going through a shared disaster. At the very beginning of COVID, before politics and all the other stuff got in there was that shared stuff. I remember going around to my house. When you go to a conference, a lot of like handouts they give you, and big thing at the time before COVID, and especially during COVID, was hand sanitizer. I remember going around to all the different old conference bags that I have and pulling out the hand sanitizer and dropping it off at like the police departments. Just trying to do my part, whatever I can, even though it's a very, very, very tiny part. It was something that I felt connected to do. My brother's a police officer, so I felt like I can't help him. I'm going to help somebody that's close. Maybe somebody near him will do the same thing. That is the connectedness that drove me to that self-empowerment. You don't need to wait for somebody like me to tell you, hey, there's somebody sitting over there that looks like they're upset. You already know how to do that. You already know what you're looking for, right? You know all this information. You've sat through this information. You've seen the statistics, the prevalence, right? 19% have an anxiety disorder, and 8% and change have depressive disorders. Forget all the other stuff. That's a lot of stuff to deal with on a good day in the prevalence of the United States. Now we're talking about dealing with some type of trauma, and those numbers are going to go up with the group of people you have in front of you. So expect that. Don't think like, all right, maybe I'll be dealing with this. You will absolutely be dealing with that the first minute you're in a deployment. People are going to be anxious. They're not anxious, they're going to be upset. They're not upset, they're going to be angry. They're going to be something. And you could see on the right side, and I'll go over those in a few moments, what those emotions likely are going to be. It could also instill a power, the power of hope. Katrina, Sandy, COVID, these are all things that some did not survive, but society, the world as a whole, did survive. And people will catastrophize when they are in a catastrophe. It's something that, you've heard the term misery loves company. It's a shared experience. It's connectedness. It's just the pessimistic view of it. If you want to try to install a sense of hope. Your job is not to heal this person. Your job is to just try to keep pressure on that metaphorical wound until the doctor or whoever can get in there and fix the wound. That's not your job. Your job is just to stop the bleeding. You're not there to save the arm. You're there to stop the bleeding, to save the person. Because people could do dumb things when they are traumatized. This is when people's fight or flight responses aren't working correctly. There's something called amygdala hijack. I think we went over that, where the most rational person does something that is less than intelligent because they are having some type of reaction to a very scary situation. I saw this also out there, the 3 L's: look, listen, and link, right? Look for somebody that could use your assistance. You're going to have people that come in families with friends, and you're going to have people that were potentially living on the street alone already. You're going to have people that are coming from group home, congregate care. You're going to have people, you live in a city, you're going to have people that don't live in Philadelphia that will potentially be needing these things, that are going to be scared, not only because of what's going on, but because they have no creature comforts or assistance or anything, because they took a plane to get where you are, right? Your guys are in a major city. You're going to be dealing with people that don't speak the language. You're going to be dealing with people that don't understand what's going on. All of those things too. I don't think of those things in my suburban MRC. You guys have another level to deal with, where you're thinking about not just who lives there, but everybody that's visiting. The time of year that people are visiting. I know in New Jersey, our population goes up almost double on the Jersey Shore this time of year. That's something that you guys should be thinking about when you're planning those proactive events, as well as the reactionary, unfortunate events where you have to dig in and stick around. Obviously, prevention and preparedness are those things that Tori and Sonia are there to lead you on. That There's times where you're going to be deployed out by yourself, and it's up to you to look for those people that really need it most. Again, I talked about nonverbal communication. Just because somebody can't speak verbally to you doesn't mean you can't communicate with them. Somebody that speaks a completely different language than you can treat them almost the same as you would if you were trying to communicate, like I told you previously, that is a nonverbal speaker. So if you can't get somebody to understand your verbal language, go to your emojis. That's a universal thing. Draw a picture. Use I'll show you these in a moment too. It's a watermark. You could barely see it, but if you can, I hope you can. Um, this is a chart for identifying pain, and you've all probably seen this in a hospital or a physical. Somebody's trying to identify your pain on a scale from 0 to 10. What you'll see sometimes are these smiley faces, right? One is extremely horrible, crying, red face, eyes are tearing, blood shooting out of the head. That's a 10. It's the worst pain you've ever been in your life. A big happy smiley face is a 0. But you can use that scale for so many other things. Are you feeling anxious? Are you feeling scared? Are all those different things? You can ask and listen about that. And then listening the best that you can. Even the connection of sitting down next to somebody, even if they don't speak your language, and just bringing them a bottle of water, a soda, candy, whatever it is you have available to you. One of the most easiest ways to develop rapport with another person is food and water and comforts. Go back to that Maslow's hierarchy of needs that we also talked about. The very beginning is physiological needs. That's where we feel. And when our world is turned upside down, we want our most comforting things. There's a reason why psychologically you want your mom's mac and cheese or your mom's meatloaf or whatever it is you may have grown up with. It makes you feel really nice and cozy inside. It's a psychological thing. You feel, and regressing back to a time in your life where there was this food that made you feel good and warm inside, because it's one of those primary psychological needs that we have. So that's why food becomes a comfort for so many people, and why somebody like myself and somebody like you as a volunteer use that as your advantage. Grab a blanket, grab a pillow, whatever you can do. If it's a kid, grab a piece of paper and a pencil. They don't care. They really don't care. They just want to like draw on something and do something other than just staring at you. Get creative, see what you can do. And then on the final side of that is link. You want to try to link them, even if it's to your coordinator, your MRC coordinator, who's going to be linked with the Department of Health, to say, hey, there's a person that was here last night. Is there any number I can give them, or a name that I can give them that could link them? I just want to make sure they have something. I would bet, I haven't seen it, but I would bet you probably already have those types of resources. If you don't, it's something that you should. And if you're somebody that is really interested in what I'm saying, another piece of advice I would give you is don't wait for those printed pieces of paper to come. Put them on your cell phone, put them in your photos under favorite storage, put a new folder there or something, so that you have that readily available. I can't tell you how good somebody will feel who needs your help, that will feel that confidence out of you when they need something out of you, right? We get on airplanes these days. That's the second time I'm talking about an airplane. And this is something I always have a joke with my wife about. We always want to see, we don't want to see a kid flying our airplane, right? We always want to see an older person. Doesn't matter what they look like, doesn't matter, male, woman, whatever, as long as they're older. Why? Because we just have this sense of responsibility with an older person, and it's a safety thing. Because they have that confidence about them. That is something that you can also do. People that are coming from a very disorienting situation want to have that consistency. So that's where you guys come in. What people are going to feel a lot of is confusion, fear, again, that hopelessness and helplessness. People are going to feel helpless. That's where you come in. There's so much more that you're going to do for those folks in their first hour being with you than somebody like me will do in the next 10 weeks of their life. Truthfully, because the things they're going to be talking about isn't the fact that their apartment burned down or somebody got sick. It's going to be the emotions associated with that event. The moment that event happened, onward. That's where it happens. So it's going to be the event itself, how it was witnessed, and how they coped with it from there on out. So there's a lot of things where you can be helpful with, even sleeping problems. You can talk to them about it, caffeine, all these things that you've learned of. It's fodder for conversation, for connectedness. People might be in physical pain. They may have had to have escaped something. Anxiety, anger, grief, shock, aggressiveness. You might have some people that are really keyed up and just need to be able to talk to somebody. And it's okay to say, hey, seem like you need to talk to somebody. You want to come and talk to me, that kind of thing. And I have bolded here, shaken religious faith. Religion gets into its own category of a conversation where a lot of people don't want to talk about it. They're uncomfortable. And that can be tough if you have somebody that's very religious in whatever religion they're in. But it's something that it's okay to try to talk about. I myself am of the Jewish faith, so we're a very small part of the population. I am very used to people assuming that I'm Christian or Catholic for a number of reasons, and that's okay, right? We don't get upset about Merry Christmas. We don't none of those things. The point is that I can sit there and have a conversation with somebody in a faith-based discussion without making them uncomfortable by saying, oh, well, I don't celebrate your religion. You don't need to get into that because there's lots of different religions out there. You're having a conversation in general about something that's larger than yourselves, right? Something very big just happens in this person's life, and something has driven them to that faith for whatever it is and how you feel about it. It's something that they have faith in, and there should be a respect for that. And when that gets shaken, that can really disrupt somebody's foundation. Remember, first week we talked about suicidality. I told you that religious faith used to be considered a protective factor for somebody that was suicidal, meaning if somebody was a devout Catholic, we in the past would have taken their word for it that they weren't going to hurt themselves because of their fear of damnation, right? So those things used to be something that we would really take in. We've done more research and we know a little bit better about all those things, but it's still a conversation that you can have with someone. Again, it doesn't say speak. It says look, listen, and link. It doesn't say anything about having good advice. I'll tell you, as a licensed therapist working in crisis settings, it's not the advice that I give because I don't give advice. I listen, I reframe, and I spit it back to the person. Okay, so it sounds like you went through this or that. You can disclose, like I've been disclosing some personal information to you guys because I think it's important for that trust. Some of the most important things is developing rapport, trust, and unconditional positive regard. Those are the tenets of basic counseling. Unconditional positive regard, if somebody's sitting there and they've just been extremely aggressive, yelling at somebody, screaming, and now they're hysterical crying because they are just all over the place emotionally. Unconditional positive regard means I am going to listen to that person, whatever just happened in their life. I'm trying to empathize to understand what made them just react that way. It's not about them disrespecting me at this point. It's about me trying to put myself in their shoes to understand why they reacted to me that way. Because I didn't cause the issue, right? I didn't cause the disaster. I'm just the person that's standing in front of them that is taking that on right now. And as a therapist, not you, as a therapist, that's my job. That's my duty, especially in a crisis setting. For you, you can listen to the point that you can, and just listening usually deflates a person. A lot of times, especially if you have somebody aggressive, and I mean like verbally, not physically, they're being like nasty, attitudinal. Sometimes just listening is the best thing, and just say, okay, don't agree with them by patronizing them, but trying to just understand what they're saying and saying that I'm just trying to understand what you're saying in a very even tone can really deflate that balloon of anger very, very fast. Sometimes people just want to be hurt. That's all they want. A lot of these like videos you see online, people fighting with law enforcement fighting with people. A lot of it's who can get out and say what they wanted to say first. And it's a contest. Who's going to say what first and last? Who's going to get the first word in? Who's going to get the last word in? And so many conflicts in crisis, in disasters, begin and end that way. So your job again is look, listen, and link. Okay. We are rounding out to the end of the hour, so I am going to talk about this one last thing and then shut up. Knowing your own self-care. This is something that does not get a lot of attention, and it absolutely should. 2 minutes left to tell you, know your own limitations, know what triggers you. There's a concept called transference and countertransference. It's talked about in any type of counseling, psychological profession, psychiatry, nonetheless. Anytime you're talking to somebody about their emotions. Transference is when, as the professional, so me talking to a patient or whoever, I will start feeling something about them. They're reminding me of something emotional that's bothering me, and then it's going to affect how I react to them. This is a concept that happens where you might have somebody, now you're the professional as the volunteer, and somebody reminds you of your daughter, your son, your father, your mother, and now you've got that emotion behind it, right? Just knowing that it exists, know what you're doing. And this happens in life a lot too. Sometimes it happens with a boss, somebody that's working for you, somebody working with you for whatever reason. Man, this person really reminds me of my mom. And, sometimes people love their moms and sometimes people have mommy issues. Same with dads and all of that. Again, it's a reference point for your own understanding, your own self-care. If you're in a situation where that transference is happening a lot and you don't like it, you need to figure out something else that you can do to help people. Countertransference is the same concept, but in reverse. Now, the person that has just escaped their, disaster is now feeling a certain way about you. So I might remind somebody of their dad or their brother or their whatever, and they have a reaction to you, which could explain why somebody might be getting aggressive or whatever. The other thing is, watch your repeated exposure. COVID was a long-term situation, public health emergency, whatever we want to call it. Some people over time, repeated exposure cause their own post-traumatic stress disorder. Not that it's the same thing, but sometimes we get literally triggered by sounds, sights, or whatever. To this day, my cell phone remains on silent almost 98% of the time. I used to run a statewide crisis unit response thing, and it was 24/7. It never closed. And I was in charge of it during Hurricane Sandy when it really hit the fan in New Jersey. And I lived at the Jersey Shore at the time, still do. Because of that, my phone just rang and rang and rang, and there wasn't anything I can do. And that went on for weeks because our infrastructure was really, really bad. Some staff members' homes were condemned, things of that nature. And that repeated exposure is what causes me to avoid, literally to this day, phone calls and any job that has on call, things of that nature. Now I'm working for a living. You guys are volunteers, as am I. But it's just, again, something I needed to tell you as a professional, just to look out for yourselves, because you're volunteering, you're doing the best that you can for everybody, and that's awesome. You want to give back. But at some point, if those in-person things start to get a little bit too much, talk about your own self-care. Maybe see somebody or talk about it. There's lots of different things that are out there, but always remember you. Again, if you're being deployed, something's not going right in your backyard either, and you gotta take care of yourself before anybody else. I'll make it a third airplane reference. They always tell you if you're on an airplane and the oxygen masks drop below, you have to affix it to yourself before you can help the child next to you. Because if you pass out, then you can't help them. It's the same thing. If you pass out from too much exposure to trauma and mental health issues and things of that nature, sometimes you got to do your own self-care, take a break, or stop completely. I know we're past 7. I'm going to stop sharing at this point, give you guys a minute to ask me any questions. And if not, it's been an absolute pleasure. I hope that this has been helpful for you, whether you listen to one or all 7 sessions or somewhere in between. It's absolutely been a great opportunity to give you guys this information. And to let you know, we will be listening to your feedback. Please provide it. We want to try to spread this message to other MRCs across the country. You guys are the pilot. You guys will be talked about at conferences within the year. And hopefully we can try to recreate some stuff and get you guys more engaged and figure out how to best serve you all in the future. So thank you. I hope to see you at some MRC event at some point if we ever do something across the Delaware River together. And I wish you all the best. Any questions? If not, I will wish you all a good night. You're very welcome. Thank you. I appreciate that, Julie. Okay, everybody. Have a good night. Satori, I will speak to you in a couple days.
Thank you, Jason.
Take care.
Good night, everybody.